everyone, and welcome to our podcast. I'm your host, Dr. Harshita, and today we are diving into an exciting topic: advances in HNC treatment. Joining us today is a true pioneer in the field, Dr. Sandeep Nayak, Director of Surgical Oncology, Robotic and Laparoscopic Oncology, Fortis Cancer Institute, Bangalore. With a remarkable 24 years of medical experience and a focus on minimal access surgical oncology for the past 15 years, Dr. Sandeep is a leading voice in the fight against head and neck cancers. He has been featured as Dynamic Leaders in Outlook Business December 2021 and Leaders in Healthcare by Forbes India in Feb 2020. He has also received K. Subramaniam Robotic Innovation Award 2023 for robotic thyroidectomy and in 2022 for Raya Mind. Welcome, Dr. Sandeep.
Thank you.
Thank you. It's a pleasure to have you today. So, Dr. Sandeep, before we begin, could you share with us your clinical journey and experiences thus far?
Well, I started with my, basic medical degree, that is MBBS from Kasturba Medical College. Then I went to do my general surgery training from Calicut Medical College. After that, it was my surgical oncology from Calcutta, Chittaranjan National Cancer Institute. Practically, it is one of the oldest institutes in India. But it has a very interesting history also, that hospital. So that in fact, it was the land for that hospital was actually got by Mahatma Gandhi.
Okay.
And that hospital has a distinction of treating one of the Nobel awardees also, the future Nobel awardees. Marie Curie came to inaugurate that hospital. So very interesting history, just to take you back to those olden days of that particular hospital. So that's where I did my surgical oncology from. And from then on, it has been a journey. I have worked in Kidwai. Kidwai is at Kidwai Hospital, Kidwai Memorial Institute of Oncology, which is a premier oncology center in Bangalore. It's a training center also. We used to have a lot of PGs and MCH trainees in surgical oncology and all that. So from there, I finally, in 2017, I resigned and came out into complete private practice. So that is how the journey as a, what you call the brief CV of it is mine is concerned. But all along, I have been thinking of newer things and getting into newer innovations and doing things. I've been always into research from the beginning. So that is how the career has been, and that's how the things have shaped up over the years.
Incredible journey, Dr. Sandeep. So now let's get started with our discussion. So, Dr. Sandeep, we would like to ask, can you discuss the role of robotic surgery in the treatment of head and neck cancers and how it has revolutionized surgical approaches in recent years?
See, head and neck cancers include multiple things. It is not just one or two. See, it starts. Some people think brain is head and neck cancer. It is not. Brain is actually considered brain tumors. It's a separate entity. But anything other than that, in the head and neck region, is included under head and neck cancer. Now, initially, when we talked about these oral cancer, not oral, oropharynx, means the back of the throat, the throat, and voice box, and all this. If we had to do a surgery for any of these areas, it was a very macabre surgery. It was a difficult surgery. Especially the base of tongue, means the back side of the tongue, was one of the most difficult areas where we had to cut open the jaw and approach it, what we call as mandibular swing surgery. So there, many of the surgeons, started reinventing and using the robo for doing the surgery in that area, which is called as transoral robotic surgery. Means robotic surgery that happens from the mouth. We do a transoral robotic surgery. So with that, we could completely eliminate the use of that wound, that face cut over the
Yeah.
face, cutting the jawbone and joining it, because once you cut the jawbone, patient swallowing is difficult, recovery time is enormously prolonged. So all that could be avoided by doing this. So there was a phase shift in the treatment of the cancer in that region.
Mhm.
Then other things also started coming into picture, like what about thyroid, what about the uh, the neck dissection, means lymph nodes in the neck which has to be removed.
Yeah.
So all these things people started thinking about as to, could we do something. Here the main concern was, can we avoid a scar in front of the neck? It's not that can we make the surgery better or anything like that. It was all about scar, it was all
Mhm.
about beauty. So that is how the scar, doing surgeries from the remote access came into existence. Like, the Koreans started doing the thyroidectomies and neck dissections from a wound from the back of the neck.
Okay.
That's called
Mhm.
retroauricular or facelift approach. Same with some of them also started doing surgeries from the armpit,
Yeah.
but they were all big wounds, like 10 centimeter wound and all. So through that they could go do the thyroidectomy or do neck dissection and come out. So these things started changing over the years. But then when I started doing robotic surgeries, when I had the access, so I had to, because I didn't find these things very interesting, because we are putting a big wound, you're
Yeah.
not putting it through small wounds, you're putting a huge wound, but only thing you're doing is you're taking it behind.
Mhm.
So that was not something which interested me. So I started looking at, can we make it more minimally invasive, smaller wounds, skin cuts will be smaller, recovery I felt would be better. So this is how we started. I started doing my own techniques, which you spoke about, that robotic
Yeah.
thyroidectomy technique called Rabbit, and the technique of Riamind, which is the neck dissection technique. So many newer things I started inventing. So you asked me, what is the impact of
Mhm.
robotic surgery in head and neck cancer? One is, it has made the surgery less traumatic, especially for the larynx, that is vocal, the voice box or pharynx, these cases. And when it came to neck dissection, that is neck area, that is thyroid and the lymph node dissection in the neck. There are many other conditions in the neck which we do. Like even there is something called thyroglossal cyst, that also we operate like that. We do parotidectomies robotically.
Mhm.
So all these things predominantly was for scarless surgery. So this is the shift which happened. But if you ask me today, I would say it not only made the surgery scarless, it made it better, because
Yeah.
robo magnifies.
Yeah.
So that magnification of robo really makes a difference in identifying structures and making it better. So there are many very tiny structures in the neck, head and neck region, which require to be saved. Like there is something called parathyroid, which is responsible for blood, calcium in the blood. So the visualization of that is far better when we do robotically, because of the magnification. There is something called indocyanine green which we use. So all these things add up and make surgery better. So if you ask me today, but if you ask me what might happen in future, I
Mhm.
think some amount of robotics will be used in every surgery, whether it's open or minimally invasive, because of the advantage of this magnification, the precision, the technology, and all that. So as of today, this is what it is. So future, I think this is what is going to happen.
Yeah, fascinating, Dr. Sandeep. And now, moving on to next question. How has the integration of this robotic technology improved the surgical outcomes and patient recovery times in head and neck cancer procedures?
Yeah, in a way, I answered you in the
Yeah.
previous question itself. But you see, overall, when you talk about the oropharynx, that is back
Mm.
of the base of tongue, that is back of the tongue, and all those cases, the recovery time is enormously different. Like, because, these patients go without any cut anywhere. You're directly entering through the mouth, just removing that portion and coming out. So
Mm.
the recovery is phenomenal because at least there is a reduction in the hospital stay by 50%. So 50 to 60% reduction happens. So that is the impact. When it comes to robotic thyroidectomy, like rabbit technique,
Mm-hmm.
what I have observed is our chances of the damage to the parathyroid gland, which is very important, comes down significantly. When the world literature says, the risk of permanent damage is about 6%, 10%, in 3% to 6% is what they say. For
Mm-hmm.
for normal thyroidectomy, we do, mine, about 70% of my cases are cancers. We are more aggressive in treating in that. So when we are treating very cancers in the thyroid, our we are more aggressive. So our risk of parathyroid problem should increase, but we ours is lower than the ordinary this one. So there are those advantages, which
Mm.
means patients' recovery is much faster because of that.
Yeah.
So that is what is the difference, which which is brought about. See, wound is something else. Now we are when you talk about a wound for thyroid, generally
Mm.
we say it is not as painful as any other portion of the body. Thyroid wounds are not so. Thyroidectomy wounds, open wounds are not so painful, and recovery also doesn't take a very long time. Some people develop some kind of hypertrophic scar, ugly scars in the neck, which becomes a problem. But otherwise, by far, that is my actually today, if you ask me, that is least of my problems. My problem is, how can I improve the result of thyroidectomy itself? And that is what I think the robotic surgery is ending up doing.
Yes, Dr. Sandeep. And now you have highlighted so many advantages of this technology. Uh, could you also share some challenges or limitations associated with robotic surgery for head and neck cancers? And how are surgeons overcoming these obstacles?
See, one of the major hindrances is availability of robo, which is
Mm-hmm.
improving now.
Yeah.
Second is many surgeons feel cost is an issue.
Yes.
Third, I feel is the training because see, I have developed these techniques. I am
Mm-hmm.
putting an effort to train people. There are other techniques developed by other doctors. Like there are techniques in Korea. Most of the techniques are from Korea. So they are putting their effort to train other doctors.
Mm-hmm.
So when you look at uh, overall picture, training is also lacking.
Yeah.
So, so that is because these are not easy technique to learn. So it requires a lot of assistance, lot of help to learn.
Mm-hmm.
So these are the main factors which come in the way of anybody who wants to get it done or anybody who wants to train also. So
Yeah.
I conduct training programs like now in the next month in March I'm conducting a cadaveric training program
Hmm.
for
Okay.
means we are training some every time we are training some two students so that they can go back and start the work.
Hmm.
So this is what is required in the long run. These are the things which really build the capacity to do advanced work among doctors.
Yeah, great. And Dr. Sandeep, you have performed like 9,500 surgeries. So, could you share like how do you approach patient selection and pre-operative planning for robotic assisted procedures in head and neck surgery?
See, when we there is by dictum.
Hmm.
There are for head and neck surgeries as such. See, there are some contraindications to do robotically.
Yeah.
More than contraindications, I would say that there's no benefit in certain cases. For example, if we have to do a free flap reconstruction, any head and neck reconstructions, like we are removing jawbone, we have to reconstruct.
Mm-hmm.
So in those scenarios, using robotic for neck dissection will be a useless thing, because anyway you have to remove the structure and reconstruct the structure itself. So there is no point in really using it. Outer structure is going. So there are certain very clear areas where it does not help at all. But apart from that, most of the situations will be able to use robo if neck dissections or most of the things. In thyroid, as of today, for everything we use robotic. In fact, I don't find anything difficult to do at all, because we are doing 10 centimeter, 15 centimeter thyroids extending into the chest. So with thyroids with lymph nodes across the neck, all these patients we are doing robotically.
Okay.
So there is, as such, there is no limit. So, and when patients come also, to me, when they have come, nobody, most of them ask for robotic surgery. That's why they come to me. So it's many times, I have had to tell patients that this is not suitable for robo. This will be done open or laparoscopic. But they think they come to me because they want to get it robotically done. So that is the thing.
Yeah. What are the some potential future developments or advancements in this technology that may further enhance surgical outcomes?
See, when it comes to technology, it'll keep on advancing.
Yes, for sure.
Right?
Yes.
It's not going to change. So as of today, we are in the second generation of robo, not the first. This is the second generation of robo. In the next generation, probably we'll have biomimicry. Biomimicry means it'll behave like a biological movement. Like, for example, it's already there in a way. For example, there is a robo which can go into the windpipe and take a biopsy from the lung. Nowadays, it is a rigid bronchoscope. Bronchoscopes are very not so flexible. So now there is a technology which can go into nook and corners and take a biopsy. It's a robo. A lot of newer things are coming. It's already released, but not there in India, but it's been released somewhere in the world. So similarly, in the future, there could be nano robots. For all you know, you might have to just inject that robo from blood and it will go where whatever surgery has to be done, it will come and do it. So there are these newer technologies which will come. See, currently what we generally say is there is there are three types of robos: passive, semi-active, and active. Passive means, like, what we have currently, what I as a surgeon use, that is, it's called master and slave robo. Wherein it is, I am the master, I operate the robo, and the robo mimics whatever I am doing.
Yeah.
So that is the master and slave. The slave is the robo.
Yeah.
Okay. Then comes the semi-active robo, the orthopedic robo, which is there. You might have heard it, where they do for the knee replacement or hip replacement. There is a robo called Mako. So that is a semi-active robo. It is not doing anything by itself, but it makes the surgeon not do any mistakes. It gives those parameters. It will make sure that the surgeon doesn't go beyond a certain point. It gives that parameters, it sets, and the surgeon operates in that parameter. So it is a semi-active robo. Active robo is like your industrial robo as of now. It is not used much in humans. It is given instructions. It is doing its own work. For humans, it has not reached there yet, because nobody will go and lie down and give their life in the hands of a robo, because there's no liability for the robo, right? If something goes wrong, who's going to take the blame? The robo company has to take the blame. With cars, it's okay, but or some other industry, it's okay, but human life, it's too much of a risk to take.
Yes.
So There are some active robots which are there in health, medical also, but they are only for biopsies and all that, neurosurgical biopsies and all that. So, future of robotics is there. It's a huge future. AI could be included. You could just simply plan the entire thing in the robo, and that robo might go and execute the plan by itself. It can happen, but it
Yes.
may take long time to happen. That's the only thing.
Yeah. Now, lastly, Dr. Sandeep, can you share any success stories or notable cases where this robotic surgery, has made a significant difference in treatment of head and neck cancers?
We operate a lot of
Mm-hmm.
patients with head and neck cancer robotically. So, and we change everybody's life,
Yeah.
right? So there is nothing unique about any particular patient whom I had to talk about.
Mm-hmm.
Every day, whatever we do, we end up doing a lot of unique work. So I don't see a point in really pointing out certain patient that okay, we did something very different for this particular patient. It doesn't happen that way. But a few things is, see, when initially when we talk about any new technique, like we're talking about Rabbit or Reamind or any of these things, these techniques will always be compared with open surgery, right? People will want to see, what is the result? And that result is actually seen in, for example, in thyroid. After every thyroid cancer, we generally give what is called as radioiodine therapy. Radioiodine to eliminate the remnant thyroid tissue, normal or abnormal. So, but when we very often, when I send my patients to the nuclear medicine doctor to give radioiodine, very often I get a feedback that there is nothing to eliminate, it's all clear. Even in patients where we have done extensive lymph node dissection, they tell, no, it's all clear, you don't need to give radioiodine. So that in a way indicates that, the quality that we are achieving with robotic surgery, which
Mm-hmm.
is very difficult even in open surgery. So, and these are the things which makes me believe that our quality of work is far better than what we could achieve with open surgery. It's not about scar, it is all about quality today to me. So that is the story which I have when I talk about it. It's not about one. I have had like
Yes.
in the past few weeks only, I have had like 3 or 4 cases where they called me up and said, means the nuclear medicine, many, not more than three, four.
Mm-hmm.
Or, there is hardly any disease. We don't have anything to eliminate. So we are thinking of not giving radioiodine.
Yeah.
Okay. So that is the scenario. So that is the testament to the quality of work that happens when we do robotically.
Great, great, Dr. Sandeep. And so, thank you. Your insights have been invaluable in understanding the strides being made in this field. Thank you so much for joining us today.
Thank you.
And before we say goodbye, I encourage all the healthcare professionals to explore our MedSynapse platform. It offers a unique opportunity to engage in enriching discussions, connect with esteemed medical professionals, and contribute to the progress of healthcare. Thank you for joining us today, and until next time, stay informed and stay healthy. Goodbye.